Good. And good afternoon, everybody. Thank you so much for joining. Today is Tuesday topic, VBG or ABG, similar and different. So our focus today really is to talk about how it is that we can use VBG and ABG for our patients. And of course, one of the reasons that we want to be able to discuss it is because a venous blood draw is just easier to do. We have a lot of approved people that can do a venous blood draw. We might have a specialized group of individuals who do arterial draws. And we're not talking about an A line now, we're talking about doing an arterial stick. A lot less complications, especially related to thrombus formation or hematoma formation that can occur with an arterial stick. If you're not holding pressure, if your patient is coagulopathic or on anticoagulations. So really important to remember that. The other thing that's important, and many of us don't really actually recognize how very painful it is to actually get an arterial stick, particularly in the hands of somebody who might not be fully experienced and they're doing a little bit of sticking and in and out a little with the needle and moving the needle around. It is incredibly and profoundly painful to have an arterial stick. I've had 3 in my life, unfortunately, all within the same hospitalization in a teaching hospital in Massachusetts, a resident to fellow. And I have to tell you, not one of them actually gave me a great stick. And that was at a time actually when respiratory therapy and nurses weren't doing arterial stick. I have a sense that if you're doing it more frequently and you're doing it all the time, you're going to be much better. So venous stick is much easier. We don't really need training. We don't really need certification. It's pretty straightforward. The veins are close to the surface and very significant decrease, of course, in vascular injuries. So that's why we really want to do a VBG. Now, it is important to understand that an ABG is going to be more accurate than a VBG. We like the ABG because the ABG is going to give us a really great assessment about lung oxygenation, and that's really important. I want an ABG for an SaO2 and a PaO2 that is actually telling me about lung gas exchange. But between the VBG and the ABG, I'm going to be able to really look at tissue expression, respiratory effects at the cellular level, bicarbonate utilization, the pH, all of which are really about cellular function. I can use VBG just as well as I use ABG. So when I draw a venous gas peripherally or centrally, I'm really using that gas most particularly to look at the presence or absence of metabolic acidosis. And I'm going to use the term here, respiratory acidosis, but I'm not talking about ventilation acidosis. I'm talking about cellular respiration, which actually will cause a high presence of PVCO2. So we do have a basic understanding here. Is really straightforward. Bicarb and base deficit, and so they're basically the same centrally as they are peripherally. The pH centrally or from an arterial line is going to be a little bit higher than the peripheral pH, and the CO2 from a central axis or an arterial line. So it says central, but really arterial is what I mean here, is going to be a little bit less than drawing it from the periphery or drawing it from the vein. So we do have a conversion table that basically says if you did it from an artery, here's basically how it will look in the vein if all things are equal and the problem is actually related to cellular dysfunctions. Not always. So that, of course, is important. If your patient is hypoxic, VBG is not the best method for evaluation of hypoxia. Not so much so that when you draw a venous gas or you send a venous gas and it's from a central line or a peripheral line that you should ignore oxygenation. It's just not effective for evaluating lung oxygenation, or what you would typically call hypoxia. So that is really important when we're considering this, that I can use your VBG to tell me about tissue oxygenation, but not about lung oxygenation. And by the way, the reverse is true as well. I'm going to use an arterial gas to tell me about lung oxygenation, but it doesn't tell me about tissue oxygenation. So that's really important. If I'm really trying to understand what's happening with my patient, he's critically ill, he's on aggressive vasopressor therapy, I think he's in shock, he's got refractory hypotension, I need an ABG and I need a VBG. And I'm not going to really expect those numbers to be relational. They may not even be causally relational. So I'm not expecting those numbers to be the same. I'm actually expecting them to be really, really different. But you can use your VBG to give you a general rule of thumb about what is happening at the cellular level, but you can only actually marry that totally to the VBG analysis if your patient has good and adequate perfusion. So in the simplest way, adequate perfusion, I'm going to evaluate by looking at the waveform of your pleth. That's the waveform that I get with your pulse oximeter. That has to be a good waveform. It has to be constant. It can't disappear. I can't be having to change my pulse oximetry sensor all over the place, one finger, the other finger, the head, the earlobe, the nose. What I really need is a good sensor that actually displays a good perfusion waveform, and that would be the pleth. If I have a good perfusion waveform with my pleth, then I can say, probably don't need an ABG if I have an adequate pulse oximetry read from the peripheral reading. If I can't get a good blood flow reading, I'm going to need an arterial gas. If the picture from my venous gas or my venous sample doesn't add up, it looks different than how my patient is looking. He's working hard to breathe. He's using a lot of accessory muscles. His SpO2 is very variable. I need an arterial gas. I don't think you standardly need an arterial gas on somebody who's on a ventilator, who's stable, who has a good pulse ox, who has good end-tidal CO2. Don't think you need a gas. Don't think you need an arterial gas. Don't think you need a venous gas. I really need that level of laboratory analysis in somebody that I am actually working hard to resuscitate and I'm having some failure in resuscitation, or whose SATs are low, or whose end-tidal CO2 is extraordinarily high or extraordinarily low. I want a blood gas on that patient. And by the way, for me, I always see those as a match set. I want a venous gas and arterial gas done at the same time in an unstable patient. Okay, so some of you will remember seeing this before. You've seen a lot of times if you've listened to me, because I talk a lot about this and I talk a lot about what my concerns are. So I want to remind you that with an arterial gas, what we're actually looking at is lung oxygenation and lung removal of CO2. That's called ventilation. That's why I look at your PaCO2, because it tells me about how the lung is removing CO2. And I can, of course, look at your acid-base balance by looking at your bicarbonate or your base, either in excess or deficit, and your pH. So I get some rule of thumb about your acid-base status. It's not really explanatory. It just tells me it's there, that you've got a bicarb that's low and a pH that's low. I'm assuming you have metabolic acidosis, and the reverse being true. If your bicarb is high and your pH is high, I'm assuming you have metabolic alkalosis. Now, that's really important because it's not specific from the arterial gas, but from a venous sample. The venous sample allows me to evaluate cellular respiration or the production of CO2. You can have a CO2 that's twice normal in the venous blood, and then when that's presented to the lung, you're breathing fast and deep, you're removing that CO2, and the arterial CO2 may look totally normal. But when the venous CO2 is high, you actually do have a problem, and you want to pay a lot of attention to that. Now, we also know that there's something that we can use from our venous sample, that's the venous CO2, and from the arterial sample, that's the arterial CO2, and we take the venous CO2 minus the arterial CO2, and the difference between them should be 5 and no greater than 8. Anything greater than 8 means that you have a poor cardiac output. So, by the way, I'm not putting in a PA catheter. Maybe I'm not using a flow tracker or a Starling to actually evaluate your cardiac output, or I have some distrust in those methodologies. Totally cool. That's okay with me. The best methodology that we have is to do at same time, so you need 2 drawers, an arterial and a venous sample, send it to the blood gas lab, and look at the difference in the venous CO2, subtracting the arterial CO2, and that difference should always be less than 5. And up to 8, I'm going to accept, but anything greater than 8, that always means you have inadequate cardiac output. So I'm going to use that to help me resuscitate my patient. That's the delta PCO2. I am going to use that like crazy to help me resuscitate the patient. There's so much evidence that supports this, and in very high thinking hemodynamic centers, that is a methodology that is employed. The other thing I can use in terms of endpoint of resuscitation, not nearly as succinct or actually focused, but still gives me some good information, is the SCVO2, the saturation of my hemoglobin with oxygen measured from here, only the central vein. Okay, so really important to think about, why do you choose what? I'm going to choose an arterial gas when I am concerned about lung hypoxemia or lung hypercarbia. So I'm looking at the lungs when I'm doing an ABG. But when I want to look at the tissues and the cells, I need a VBG. So that's the way for us to always think about this. I'm evaluating the lungs with the ABG. I'm evaluating the cells with the VBG. That makes a really important difference in our mind in terms of how we're going to utilize that data and why we want to do those gases. I'm not worried about your lung oxygenation because you have a pretty good SAT and you're on 50% FiO2 and 8 a PEEP, and you have a pretty good SAT, but you have metabolic acidosis and it's getting worse. I need a venous sample because the probability is that you have poor cardiac output. You have good saturation, you have good oxygenation, but you don't have adequate blood flow. And that's what the venous gas is going to tell me. It's going to help me to focus on the care of my patient and look at what's really meaningful. Okay, so for respiratory, and when I say that, I probably should have changed that term. For ventilation conditions, oxygenation and CO2 removal. So we're going to loosely call that respiratory, but really it's about your pulmonary system. So pulmonary conditions. Is my patient hypoxic? Does he have respiratory failure? Is he retaining CO2? Do I need additional ventilatory support? And is my support working? The arterial blood gas is really helpful. So again, I want you to focus. The arterial gas is really about pulmonary management. The venous sample, also you can get it from the arterial sample, but it's much more meaningful from the venous sample, is to actually see what's happening at the cellular level. Is the venous CO2 high, which means your cells are anaerobically producing carbon dioxide? Is the metabolic acid high? I'm not measuring metabolic acid. I'm measuring the opposition of the metabolic acid, which would be base or bicarb. So your base is in deficit, your bicarb is low. That's going to be really helpful. And then I'm also mentioning, and I'm sorry it doesn't say it here in terms of metabolic conditions, your PV minus PaCO2. Remember, the difference between the two should be less than 5. I'm going to accept up to 8. But if it's greater than 8, that is telling me that I have a metabolic disturbance and that I have an inadequate cardiac output. So really important to appreciate the difference between arterial gas and venous gas and the way in which we're going to use those to help us drive our therapeutic interventions for our patient. So this is just a general rule of thumb of a normal arterial gas, right? Shouldn't be any surprise to any of you looking at your bicarb, your base, your O2 sat, pH, CO2, and PaO2. This is your normal arterial gas. And remember, PaO2 actually gets lower the older you get. So that's always, you've always got to accommodate for that, right? Then I'm going to move here to my venous gas. And I've highlighted here these big differences. PvCO2 is 5 more on either side from arterial. So arterial CO2, 35 to 45. Venous CO2 is 40 to 50. Venous oxygenation, although I'm not using this to evaluate the lung, I need the arterial gas for that. What I am going to say is if my PvO2 is less than 36, you don't have and adequate cardiac output. So you're using a lot of oxygen from the dissolved state of the vein, using oxygen, using oxygen, using oxygen. And if my number here in PVO2 is less than 36, my O2, venous O2 sat, will typically be less than 60 because the hemoglobin is releasing the oxygen to be used at the cell. It has to dissolve in the blood to be used at the cell. So it comes off hemoglobin, dissolves in the blood, and is used at the cell. And therapy for that is not to increase the saturation, but to increase the delivery of saturated hemoglobin, and that's your cardiac output. So that's a really important concept. So you can see I'm looking at these three things as being radically different in the venous gas than the arterial gas. Okay, so now we just do a comparative analysis. Okay, this is your normal arterial, and here's your normal venous. So you can see you have only a 0.03 difference really in the pH. It's a small amount of difference because in normal process, you're going to produce a little bit more metabolic acid at the cellular level. And that's why you see that the pH drops a little bit, that your bicarb can drop a little bit, but still we're going to expect your base, which is the calculated evaluation of circulating buffers. Base goes into deficit when acid is in excess. And the acid that has to be in excess for the base to be in deficit is metabolic. And they're very similar between arterial and venous. So I'm not really worried about those. What I'm really worried about is what is your PA minus PV, or what is your PA compared to your PV CO2? What is your PA compared to your PVO2? And what is your SA compared to your SVO2? Now, again, I want to reiterate to you, I am not saying one is better than the other. I am saying they measure different things. And in really sick patients, you need both, and they need to be done at the same time. Not 20 minutes apart, not 30 minutes apart, real time, right now, same time, two blood drawers that are drawing at the same time so that I can do comparative analysis at the same time of what's occurring with my patient. So again, if my concern is metabolic conditions, or I'm concerned that you don't have adequate cardiac output, arterial gas doesn't really help me. A venous gas is going to help me. A venous sample is going to help me. If I'm looking at lung gas exchange, oxygen or CO2 at the lung, the arterial gas is going to help me. So again, arterial gas for pulmonary conditions, venous gas for cellular and metabolic conditions. That's really why we want to separate this measure, and we want to separate the way in which we consider the importance of these two different types of samples. So now I'm going to say it again in my Barbara simple way. Is my patient hypoxic in the lung? I need an ABG. PaO2, SaO2, and the P to F ratio are going to help me understand the level of hypoxia. Is my patient hypoxic at the cell, meaning that's a cellular issue, is a metabolic issue? I need a VBG. I can see if the patient is acidotic by looking at ABG or VBG, but I don't know why necessarily. I have a little list of things I can rule out, but when I do a VBG, I can really see what's occurring at the cellular level. If my PVO2 is 35, if my SVO2 is 48, if my PVCO2 is 70, my patient is operating anaerobically. And the one thing that's going to fix all three of those is to increase the cardiac output. That's what's going to treat them. So I find that the arterial and venous samples give us a very different worldview about what I need to do. So really, really, really important when we're evaluating our patient to understand the difference in those samples. So important fact one, which just summarizes what I've said, really arterial gas samples are required only when you're really trying to evaluate lung function, PaO2, SaO2, PaCO2. Venous samples are better when we're evaluating what's happening at the cellular level, and those venous samples really tell us a lot about excess respiratory acid production, CO2, or excess metabolic acid production, hydrogen, which then binds with the base, and the base goes into deficit. We never measure the hydrogen. We always assume it by looking at your base deficit. Now, it's really, really important to remember Patients in severe circulatory failure will be operating anaerobically, and they will actually have a high yield of venous CO2 and a consumption of oxygen that will drop their PVO2 below 37 and their SVO2, whether it's central venous or mixed vein, doesn't matter, SVO2 less than 60%. So that's kind of the introduction to why we choose venous versus arterial. So if I'm going to look at this patient, okay, and this patient has a PaCO2 of 39 and a PvCO2 of 45, first of all, we can say this patient isn't retaining CO2. We look first at this PvCO2, that's production of carbon dioxide. And PaCO2 is what's left over after normal breathing. We can say three things by looking at this. You're making a normal amount of CO2 in the venous bed. You have a normal amount of arterial CO2 after clearance. And the third thing I'd want to know would be, what is the end tidal CO2, which is telling me about the lung function. So I can look at this patient and say, A, he's not acidotic, and B, he is not producing nor retaining excessive CO2. PvCO2 is always about CO2 production. PaCO2 is about leftover carbon dioxide after blood has passed through the lung surface and carbon dioxide has been cleared. Okay, so now I'm going to look at this patient who presents with infection and exacerbation of COPD. If I start here in his venous gas and I say, okay, remember, normal venous CO2 is 5 plus normal arterial. Normal venous CO2 is 40 to 50. He's got a very high venous CO2. That already makes me very nervous. He also has a very low pH, so he has acidosis. I'm assuming he has respiratory or respiratory acidosis. CO2 is up, pH is down. Now I go over to the arterial side and I see that he's not clearing CO2, right? If he was clearing CO2, let's say he was breathing 30 times a minute, he was breathing a minute ventilation of 16 liters, it was a good minute ventilation, I might see that the PaCO2 is 35 because he's clearing it with adequate breathing. But what you see here is high on the venous side, high on the arterial side. What that means is he's not breathing adequately. And I'm going to treat that with a ventilator. If I need to treat it all, I'm going to treat it with a ventilator. It's not about cardiac output. It's about inadequate ventilation. So if I don't clear CO2, I'm going to see a higher CO2 in the venous bed because I'm starting with a higher CO2 in the arterial bed. This is a patient who is retaining CO2. Now I'm going to take a look at this patient. PCO2, oh, it's just exactly what I said. Isn't that brilliant? Here we are looking at the venous gas, pH 7.31. PCO2 is 66. Okay. Somehow, though, the patient has cleared that CO2, and he's doing that by rapid breathing. Okay. Breathing rapidly. Okay. And over here we see his PCO2 is 32. Now, you might have missed the fact that he's having a very, very high production of carbon dioxide at the cellular level. And when you looked over here, you said, well, his CO2 is 32, but he's still got an acidotic pH. Okay, so what I would like to remind you is rarely do you see metabolic acidosis without a rise in the PvCO2, because this is part of the anaerobic metabolism that's occurring. So I look at your venous sample and you have a high PvCO2, but you have a low PaCO2. And then I look at you and I see that you're breathing 24 times a minute and you're moving a high tidal volume. But now I'm also going to add in here your bicarb. Your bicarb is 16 on the venous side, is about the same on the arterial side, and your base is -6 on the venous side and about the same on the arterial side. You actually don't have what we would traditionally call respiratory acidosis because you're blowing CO2 off. What you actually have is metabolic acidosis. So this patient has an acute metabolic acidosis. But I, again, want you to focus that on his venous sample, you saw that high PvCO2 as well as that low bicarb. It tells you that this patient needs for you to improve his cardiac output. He needs you to improve cardiac output. So how do you do that? Volume and inotrope, not vasopressor, volume and inotrope. Okay, so how do we look now, or what do you think now? Your venous sample is 56, your arterial sample is 50. Okay, so your PA CO2 is a little high, your PV CO2 is a little bit higher than that, but the gap is less than 8, right? So not really worried that this is a blood flow problem. If I had end tidal CO2 here, I would tell you that you would see reflected in the end tidal CO2 that the patient is hypoventilated. So you're going to treat that with the ventilator. So let me see if I can summarize this. I don't have a slide for this because I just thought about it. When PA CO2 is up, PV CO2 is up, and the gap is less than 10, you typically are going to treat that with ventilation. When your PV CO2 is up, but your PA CO2 is normal or low, that needs to be treated with cardiac output. Sometimes you have a combination of both. So that's also really important. But it really guides us to understanding these similarity and differences between venous and arterial samples and really trying to make good decisions about what's occurring. Okay, so here I am with my VBG, 75-year-old man, mixed COPD, congestive heart failure on non-invasive ventilation. His first blood gas, venous sample, pH is 7.16. Well, that's disastrous. And PCO2 is 83, also disastrous. We have acute, one thing we know for sure is we have acute respiratory acidosis. It's a ventilation failure. You might also have metabolic acidosis, but we're not covering that right now. We're just talking about pulmonary acidosis, or what we traditionally call ventilatory acidosis. So I put the patient on non-invasive ventilation. I remember that with non-invasive ventilation, I'm going to help remove CO2 by increasing the IPAP, which is the pressure support, which determines the tidal volume, and maybe increasing the respiratory rate. So that's what I've done. I've increased the IPAP and I've increased the respiratory rate, and I'm blowing off a fair amount more CO2, almost 20 millimeters of mercury. Am I as good as I can get? No. And I still have a very acidotic pH here. So I would tell you that the level of acidosis, 7.28 with a chronic lung patient who has a PCO2 of 62, this patient has also metabolic acidosis. And then I'd go back to the blood gas and I'd look at the bicarb, I'd look at the base, I'd look at all my other measures to actually determine what else is going on. The word here, chronic, usually means that patients compensate for their CO2 retention. Their normal CO2 retention is between 60 and 65. So when we first saw him, we could see that he had some failure. He had some ventilatory failure, which made his pH acidotic. But now we've blown off his CO2 to 62, which is a pretty good level for a COPD, but his pH is still 7.28, which almost always means the patient has mixed respiratory and metabolic acidosis. Now, here's the problem. With a person who has chronic lung disease, you don't live with them. You don't know them. They came to the ECC. They were admitted to the MICU. You don't know that patient. He has been living for 7 months with a PCO2 of 68 and a bicarb of 25 and a normal pH. And the first time you see him, his CO2 is 83 and his pH is 7.16. And you look at his bicarb and his bicarb is 22. But normally it was 28 or 30 or 32. You don't know that because you don't know the patient. So you're thinking, oh, it's only respiratory acidosis. But in a chronic pulmonary patient, if the bicarb is not elevated, they are also in metabolic acidosis. That's really important for us to appreciate and understand, because at the same time that we're treating them with the ventilator, we've got to look at what the condition is that is promoting metabolic acidosis for that patient. So certainly, we look at this. This is time 1 to time 2, same patient that we just looked at before, pH 7.16, PCO2 83. Time 2, pH 7.28, PCO2 62. And then on the arterial side, what we see is the patient has got a fair amount of CO2 that remains in the blood, but he's also clearing a fair amount, right? He went from 83 to 61. But that gap venous minus arterial CO2 should never be wider than 10. So that has already told you that you have a bigger problem than just ventilation. Now you start with ventilation, you increase this respiratory rate, you increase this tidal volume, you do the next gases. So we look at time 2 venous versus time 2 arterial, and you can see here that you are clearing more CO2, but look, now you've dropped him down to 53, but his pH is still 7.3, and your gap is 11, which tells you you don't have adequate cardiac output. Oh my gosh, you guys, how amazing is this to give us that ability to actually truly evaluate our patient's cardiac output merely by doing comparative analysis of venous and arterial sample. Okay, we're going to come to an acute respiratory distress patient. His name is Chan, 74 years old. He has known chronic obstructive asthmatic disease, presents to the ED with a 1-day history of worsening dyspnea following a cold, very short of breath at rest, can't speak very much, only say about 2 or 3 words before he has to stop, and he's short of breath. Heart rate 125, blood pressure 140 over 80, respiratory rate is 35. Ding, ding, ding. That's big concerning. O2 sat on room air is 86, and he has reduced breath sounds with scattered bronchi, but nothing focal. He gets a venous sample. From his venous sample, can you actually see pH 7.16, PCO2 is 82, and bicarb is 28? Can you actually look at this patient and say that he's retaining CO2? Yes or no? You certainly can say it. Might not be right, but yes, you can say it. And you can also say he certainly has had some compensatory effort. He might be on the downslide of compensation because maybe he normally is at 32 and now he's at 28. But we can certainly say he has a very high level of CO2. At this point, I'm not going to be able to tell you, is this only ventilation or is this also perfusion? Okay. But we can certainly say that we know a component of this is his ventilation. He's hypoxic. Bye-bye, Sarah. Thank you so much. He's working so hard to breathe. And that's evidenced by the venous pH, which is a relatively accurate reflection of arterial pH. And even though we have a little bit of a wide limit of disagreement between arterial and venous CO2, his venous CO2 is very high, and coupled with the pH and almost a normal bicarb, which means probably on the downside, he definitely has acute hypercarbia, but I think he also has metabolic acidosis. Okay, so now we're just going to take a variation on the theme. We're evaluating him. He can speak in short sentences. He has a pulse of 110, blood pressure 140 over 80, respiratory rate of 30, O2 sat 86% on room air. Chest findings are the same as what we mentioned before, but his venous gas, pH 7.45, CO2 42, and bicarb 28. Okay, your patient is hypoxic, might be hypoxic. He's working hard to breathe, but he's not retaining CO2. And we know that by looking at his pH and by looking at the presence or absence of PCO2. So when we look at our venous gas, the most important component of your venous gas is to actually discover whether your patient is producing more CO2 or retaining more CO2. And that's really what we're looking at. Okay, so if my CO2 in the venous gas is less than 45, hypercarbia is unlikely. Okay, that means also that probability is your arterial CO2 is less than 45. If your PCO2 is greater than 45, you possibly will have arterial hypercarbia. We don't know that until we look at your ABG and your end tidal CO2. And most of the time, if it's CO2, but not a wide gap, remember, that's really important, my friends. A wide gap between venous and arterial typically is about blood flow dynamics, not ventilatory dynamics. So if I don't have a wide gap, but I have a high PV CO2 and a high PA CO2, but a normal gap between the two, I'm going to manage you non-invasively. I can't use high flow oxygen here because high flow oxygen doesn't really treat CO2. There may be some indirect effects on CO2 by washing CO2 in the conducting airways out, but high flow oxygen doesn't treat CO2. CPAP doesn't treat CO2. Nasal cannula will make CO2 worse. So I need to either put you on non-invasive positive pressure ventilation or I need to intubate you. That's all there is. There's no choice of saying, oh, let me try a nasal cannula for a little while. Let's do this or let's do that. None of those things treat ventilation. It's the difference between your ending pressure, which we would normally call PEEP or EPAP or CPAP, and your inspiratory pressure, which determines your tidal volume that I'm going to use to treat your venous CO2. And then I'm going to evaluate your gases to discover, is the treatment appropriate? Okay, now we're going to look again at this patient. Now we're going to change some things. Time 1, 7.16, PCO2 83. Time 2, 7.11, PCO2 88. Going in the wrong direction, not doing very well. Okay, I'm going to look at them in the arterial bed, 7.23, CO2 is 61. So that's a wide gap, right? That's a wide gap. Here, time 2, 7.21, PCO2 is 73. This is a more normal gap. It's almost a normal gap. So you might have normalized the gap a little, maybe gave some volume, you're on a inotrope, but now it's time for us to say, we've got to add end tidal CO2 in here to help us evaluate the ventilation. So if you've been on any class with me before, you've seen this before. I would like to remind you that the most important CO2 is the one that you produce. Production of CO2 is measured as PV CO2. Travels in the blood to the right atria, the right ventricle, up into the lungs, and is eliminated as end tidal CO2. Okay. We eliminate that as end tidal CO2, and then we look at what remains, and that's PaCO2. So production, elimination, remaining. Starting with remaining, 35 to 45. Production, it should be about 5 above, 40 to 50. And elimination should be about 5 below. So if this is 35 to 45, ET CO2 should be 30 to 40. Production CO2 should be 40 to 50. All you need to remember is what's your normal arterial CO2, add 5 for venous, subtract 5 for end tidal. That's it. Don't make it harder than it needs to be. But in order for your patient to eliminate CO2, they A, must have good lung recruitment, and B, must have good blood flow through the pulmonary bed, or else they're never going to eliminate CO2. So it's really going to be important to us to really appreciate and understand that. So again, venous CO2 reflects metabolism and the production of respiratory acid at the cellular level, 40 to 50. End tidal is the clearance by the lung, 30 to 40. Arterial is what's left over in the blood after clearance, 35 to 45. And by the way, my friends, another little remembering tool, arterial and end tidal CO2 should always travel in the same direction. So if arterial CO2 is up, end tidal should be up. If arterial is down, end tidal should be down. When end tidal is down and arterial is up, something is wrong, much worse than what you thought, and you will not be able to treat that by ventilation, my friends. That's a perfusion problem. So we always want to engage end tidal CO2. Okay, so now I'm going to move to the PV minus PaCO2. Very straightforward. Okay, it's the venous to arterial CO2 tension. And remember, I'd like to see that less than 5. If it's less than 8, I'm okay. Greater than 10, this is always an issue with cellular perfusion. Okay, cellular perfusion is PV minus ACO2. And what I'm going to do with that gap, if I've got a wide gap there, I am going to treat your cardiac output. If it's a pulmonary perfusion, I'm going to look at a gap between the PA and the end tidal. So my end tidal CO2 is 20 and my arterial CO2 is 60. The gap is 40. That should always be less than 10. So just remember 10 for both. PA minus end tidal should be less than 10. If the difference is greater than 10, you don't have pulmonary perfusion. Now, typically you don't have pulmonary perfusion because you have a pulmonary embolism. You also may not have adequate pulmonary perfusion because you're using high degrees of pulmonary pressures like PEEP or pressure control inverse or APRV. You're limiting the blood flow dynamic through the pulmonary bed. These are 2 really important measures. All they require is you did an arterial and a venous sample at the same time and you're monitoring end tidal. PV minus ACO2, gap should be less than 10. The gap is wider than 10. You need to improve cardiac output. PA minus ET CO2 should be less than 10. If it's greater than 10, you've got an obstruction to perfusion through the pulmonary bed. That might be massive PE or submassive PE. It might be minor and multiple PEs. It might also be obstruction that's actually been introduced via our methodology of ventilatory support. Really incredibly important. Every single provider at the bedside should be able to understand end tidal CO2, use it appropriately, calibrate the line before you connect it so that you're getting good readings. Every single provider should be doing it. And every critical patient needs end tidal CO2. Every patient who's intubated on a ventilator needs end tidal CO2. Every patient who's on non-invasive ventilation needs end tidal CO2. You should not be practicing without end tidal CO2 in these critical patients. So that's something that you want to actually encourage. I know that we're buying a lot of end tidal CO2 modules for critical care, and that includes the ECC. We need to really use them. We need to preserve them. We need to try not to lose them or sell them off or whatever is happening to our end tidal CO2 modules. I don't know. Got to really retain them because they're going to be really important to us. Okay, so again, just remember, I'm looking from pre to post production of CO2. So normal or central PV of CO2 is 40 to 50, normal arterial 35 to 45, and the difference should always be less than 10. And that is so well vetted in the literature, helping us to remember that we're really not just looking at CO2 as an expression of the lungs and ventilation. We're also looking at CO2 as an expression of production of acid in an anaerobic environment. Very, very important when we're talking about managing our patients. So I'm just giving you this little drawing here that just reminds you, PA CO2 normally 35 to 45, PV CO2 normally 40 to 50, and PV CO2 minus arterial CO2. I'd like to see that gap less than 5, has to be less than 8, greater than 10, always tells me that something is wrong. And that's something that's wrong is not to be addressed by the ventilator and the alveoli, but to be addressed by perfusion through the cellular network. When PV CO2 is high and the gap between PV and PA CO2 is wider than 10, this is a cardiac output problem. This is a blood flow problem. Okay, so using my venous gas, can I answer these questions? Does my patient have respiratory failure? Yes. Can I use it? Yes. Can I say that a patient is a CO2 retainer? No, I need an arterial gas for that. Do I need to provide additional ventilatory support? I need both venous and arterial, at least at the beginning. And can I see if my treatment is working? Yes, I can. With my venous sample, as the venous CO2 starts to drop, I can see whether or not it's working. Okay, so venous samples can be used for acid-base evaluation. The venous sample is going to tell me about CO2 production at the cellular level, also going to be telling me about the consumption of base and bicarb, which is going to be very informative, and whether or not I have adequate oxygen at the cell. Now, adequate oxygen at the cell, as long as your SAT is greater than 88%, is not going to be treated by more oxygen at your ventilation apparatus. Adequate oxygen at the cell is going to be sustained and maintained and delivered by cardiac output. So now I want to just add this other box to this VBG measure, okay? Shock. When I see that my PA CO2 is greater than 45 or my PA CO2 is less than 45, and I'm looking at my venous sample, I must add in here end tidal CO2 and comparative analysis to the arterial gas. That is how I'm really going to define whether the problem is the ventilation apparatus or the blood flow and tissue respiration apparatus. This is such an important and incredible tool that helps us to evaluate our patients. So now we're going to look at case 1. We went a little out of order because case 2 is just a primary respiratory acidosis patient. This is a 26-year-old with insulin-dependent diabetes. She comes to the ED. She's got a 2-day history of nausea. She's vomiting. She's got diarrhea. On exam, her pulse is 120. Her blood pressure is 140/50. Respiratory rate is 30, and there's no abnormalities on the cardiorespiratory abdominal exam. her blood glucose level is high or greater than 600, and her VBG shows a pH 7.26, a total, a dissolved CO2 in the venous bed of 16, a bicarb of 7, a K of 3.8, a base deficit of -14, and a lactic acid level of 7.2. Now, obviously, she is not a CO2 retainer, right? Because her normal venous CO2 would be 40-50. That's really, really low. Her bicarb is low, her base is in deficit, and her pH is acidotic. She has metabolic acidosis. Do I need an arterial sample? Absolutely not. I do not. I do not. Unless I have concerns about hypoxia, and I don't have that because I put a pulse ox on her and her sats are 94%. I am not worried about oxygenation. I'm not worried about lung gas exchange. What I'm worried about here is metabolic acidosis and the compensation that my patient is making by breathing fast and deep and blowing off CO2, compensating for her severe metabolic acidosis. Okay, so don't need an ABG. All I need was the VBG. I'm going to use end-tidal CO2. What I'm going to expect to see, by the way, this is going to sound so weird to you. I know it's going to sound weird to you, but the more you hyperventilate, you're going to clear smaller amounts of CO2 per breath, but you're going to clear a lot more because you're breathing rapidly. So your end-tidal CO2, remember end-tidal and arterial should travel together. Your arterial CO2 is down and your end-tidal is down, okay? When you are hypoventilating, it takes much longer for you to exhale that CO2. So the end-tidal CO2 number is much higher. That's because you're hypoventilating. And the rationale would be that during that time, it takes all that time for that CO2 to accumulate. So we look at our end-tidal CO2 as like a little square, a slanted square wave like this. And you're doing that for a delayed period of time, and you're going to read a much higher CO2. When you're hyperventilating, it's just like this. It's a really narrow wave. It's very little plateau time, very narrow. So you're clearing less CO2 with each breath, and that's why your end-tidal is down. You're hyperventilating, you're clearing, and your end-tidal is down. So with hypoventilation, arterial CO2 and end-tidal CO2 are up. With hyperventilation, your arterial and your end-tidal CO2 are down. With poor pulmonary perfusion, because you're not flowing blood through the lung, your end-tidal CO2 will be down, but your arterial CO2, because you're not flowing blood through the lung, your arterial CO2 will be high. That really gives us a lot of information. So the last thing I'm going to talk about, I'm just going to spend a couple minutes on that, is actually SVO2 or SCVO2. I don't need to make the difference between the two, okay? Our target is always 70%. Our range is around 60 to 80%. The difference between central venous or mixed venous is one is drawn or measured from the distal tip of the PA catheter. It's still in a vein. It's the mixed vein. It's not a mixture of arterialized and venous gas. It's mixed venous gas. The pulmonary artery is a mixed vein. It's just called an artery because it's going away from the right heart, and it transitions to the vein when it goes back to the left heart. So it's called an artery, but there's not arterialized blood here. This is mixed venous blood from every organ in the body. Central venous, drawn from the distal lumen of a central line, it's the only one that's meaningful. We don't think that the peripheral values are very meaningful at all. Maybe that's all you've got. Okay, fine. But we don't have really vetting for that meaning. Central venous from the distal lumen of your central line, that beautiful blood gas draw from that distal lumen of your central line actually reflects your cerebral and upper extremity utilization of oxygen. So that's why we use that. Okay, so really important to remember in either case, got to actually have a sustained change of about 5 to 10% for me to be concerned. My patient turned, he dropped from 65 to 40, and then he returns to normal over the next 40 seconds. So he drops from 65 to 40 when you turn him, but he comes right back up to 65 over about 40 seconds period of time. That's called recovery time. You sat him up in the bed. He drops his SVO2. He's coughing. He drops his SVO2. We're concerned about prolonged low SVO2s. We are also concerned about how long it takes you to get back to normal after you've had a drop. That's a little bit beyond what we want to talk about here. So we're just really looking at normal strategic values, okay? Our goal is 70%, but our goal is 70% in the absence, absolute absence of metabolic acidosis. If you have metabolic acidosis and a normal SpO2, something's really wrong, okay? So it's really important to remember SpO2 and the absence of metabolic acid. Okay, so it's really important to remember, I cannot use oxygen when it's bound to hemoglobin. My blood leaves the lung with a high degree of saturated hemoglobin, and the role of your hemoglobin is to release that oxygen if your cells need it, and if your blood flow is dynamic and the cells can get it. So my hemoglobin will desaturate as they pass through the capillaries and they release oxygen, because the only oxygen that's usable is dissolved oxygen. Okay, so really, really important to remember the saturation of hemoglobin on the arterial side told me about the lungs. The PaO2 on the arterial side tells me about what's dissolved and usable in the arterial blood, but I'm not using it in the arterial blood. I'm using it at the capillaries. So the only way I know whether it was adequate or not is by measuring it in the venous reserve, looking at PVO2, which should always be greater than 37, looking at SVO2, which should always be greater than 60%, in the absence of metabolic acidosis, because two things happen. Cells don't need it, so you're going to have a higher level of saturation, but you don't have any metabolic acidosis. Or cells need it, but they cannot get it. In which case, you're going to have a normal SVO2, but you have profound metabolic acidosis. That is really significant when we're talking about our patients. Okay, so let's just kind of review really quickly. PO2 in inspired air just depends on your partial pressure or your FiO2 of the atmospheric pressure. So 0.21 converts to a partial pressure of oxygen to about 150 or 159. So PO2 in the inspired air is FiO2 in the decimal times 760, which is our barometric pressure. And that's what you're breathing. That then mobilizes and pushes gas into the alveolar blood. That's your alveolar gas, which then pushes it into your arterial blood. Okay. And your arterial blood dissolved is the usable gas and bound is your reserve gas. PO2 down in the capillaries is around 50 to 80, and PO2 in the tissues normally is around 30 to 50. PO2 in the mitochondria is 10. But if I'm hyperactive, I'm inflamed, I'm hypoxic, these numbers, the PO2 in the mitochondria drops to 5. This number drops to 12. This number drops to 20. And my hemoglobin must release oxygen in order to restore these three, capillary tissue and mitochondria. My hemoglobin in the arterial bed has to move into that network and release oxygen. And that's what converts it into SpO2. SpO2 is what remains after the cells have consumed the needed oxygen. The more oxygen your cells need, the more you're going to desaturate your hemoglobin. So we say normal, 60 to 80, target 70, but it has to be in the absence of acidosis, because you can have a normal SpO2 with profound metabolic acidosis. Your patient has the reserve, but they're not using it. And that is so critically and profoundly important. Okay, so the PO2 in the alveolar gas is affected by your FiO2, your partial pressure, and the alveolar recruitment or capacitance. If my alveoli are filled with fluid, pus, or they are de-recruited, doesn't matter how much oxygen you blow, it's not getting to the alveolus and it won't get into the blood. Okay, so always remind yourself, you love to have that excess oxygen bound to the hemoglobin. That's reflected in the SaO2. Remember that in terms of lung gas exchange, an SaO2 of 88% is perfect. And you're still going to have a very high level of reserve for your venous bed. Okay. Oxygen gets released from your hemoglobin as hemoglobin moves through the capillaries, releasing oxygen dependent on these three things. How much oxygen do I need in my mitochondria? How much oxygen is being used in my tissues? And how much oxygen is dissolved in the capillary bed? You're only going to assume this by two things. PVO2 greater than 37, SVO2 greater than 60% in the absence of metabolic acidosis. That seems really, really, really straightforward. So when you don't have enough being delivered, the demand is high, you should always expect that your SVO2 is going to go down. And you're not going to let it stay down. You have to improve cardiac output in order to protect your patient from ongoing and worsening cellular ischemia. Okay, so we're always going to use SVO2 to tell us about these three things. We're not measuring cellular mitochondria, we're not measuring PO2 in the tissues, and we're not measuring PO2 in the capillary blood. We're going to look at your SVO2, and we always expect that SVO2 should go down to resolve any metabolic acidosis. Okay? If my SVO2 is normal and I have persistent or worsening metabolic acidosis, the first thing I have to say is my patient capable of using oxygen? So then I'll look at your PVO2. If your PVO2 is 45, but you have profound lactic acidosis, and you have a PVO2 of 45 and an SVO2 of 70, those numbers look normal, but it's in the presence of metabolic acidosis, which is profoundly abnormal. So just remember, components of oxygen delivery. Number one, most important, always the first thing you address is the cardiac output, and that would be your stroke volume times your heart rate. You're going to treat that with volume, you're going to treat that with inotrope, you're going to treat that with the heart rate. Okay. The next most important is how much hemoglobin do you have that are capable of carrying oxygen? That's the second thing. Least important is the saturation of arterial hemoglobin. And the patient himself will increase his heart rate and stroke volume to increase delivery when the cells are hypermetabolic or when oxygen is not functionally dissociating from hemoglobin. The second thing that your patient will do, remember, first we look at delivery. The second thing is that your patient will use more oxygen from the venous reserve, meaning that your SVO2 will drop. Okay. Now remember, we have to consider, do you have enough delivery? Are your tissues demanding too much? Are you hyperthermic? Are you in pain? Are you agitated? I have to control all of that. I really have to control it. And I want to understand blood flow through the capillary and tissue ability to use dissolved oxygen. I'm going to have a venous sample for that. I cannot do that from an arterial gas. That's when you must have a venous sample to tell you about that information. So now we just go back to that little visual that we had before, looking at SaO2 and SVO2, and what we expect is to see a difference between the two of no greater than 20%. If you have a gap of 20%, you are on the verge of shock. So I'm going to try to increase your cardiac output to narrow that gap, to get your SVO2 up to the target, remember, about 70%, and in the absence of metabolic acidosis. Now, we talk about this as oxyhemoglobin dissociation, meaning why does oxygen come off of your hemoglobin? That's called a shift to the right, release from hemoglobin, and that happens because your cells need it and your cells can get it. Shift to the left means that you are directed, I'm sorry, I don't have an arrow for that, directed towards the left, meaning that your saturation is normal or high, and the only time that that's acceptable is in the absence of metabolic acidosis, my friends. That's the only time. So when we see a shift to the right, that means release, release, release. SVO2 is less than 60%. Cells need it and cells can get it, but I want them to stop it right now because they're taking oxygen from their reserve, and any little incident will put them over the edge and put them into shock and multi-organ dysfunction. SVO2 with a shift to the left, meaning normal to elevated. Cells don't need it, or cells need it, but they can't get it. And the difference between that, when cells don't need it, you don't have metabolic acidosis. If cells need it and they can't get it, you will have metabolic acidosis. This is particularly important when we talk about use of vasopressors. You're treating your patient's blood pressure. You've driven the map up, but their base deficit has gotten worse and worse and worse and worse. What you've actually done now is you've created a shunt, blood moving from artery to vein without passing through the capillaries and without appropriate oxygen utilization. So lots of information about why do I do a venous gas and an arterial gas, and really trying to appreciate why both are important. You don't need all of them all the time. You need to do a venous sample when you have concerns about your cells. You need to do an arterial sample when you have concerns about your lungs, and you need both when you're not sure what the problem is. That's really the beauty of being able to do venous and arterial gases. So again, I would like to say thank you to everyone who's joined me on the phone. Please stay on the line. I'm going to end the recording, but then I'm going to come back and we can have some questions and answers. Thank you very much for sharing today's Tuesday topic. I really appreciate all of your effort and your desire to increase your knowledge and manage your patients.